Hello, everyone. Welcome to today's live broadcast, Cure Educated Patient Lung Cancer webinar. I'm Dr. Charu Agarwal, Leslie Heisler Assistant Professor for Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia, Pennsylvania, and I will be your moderator for today's event. We are pleased to bring you this webcast presented by Cure and sponsored by AstraZeneca and the Longevity Foundation. We have a few important announcements before we can begin. You will be receiving a survey via email tomorrow. As a thank you for watching the full webinar and completing the survey, you will be entered to win one of two $200 Visa gift cards. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found at the bottom of your screen. If you have any technical problems viewing or hearing this presentation, please click on the question mark help widget in the dock at the bottom of your presentation window. We are pleased to be joined today by Dr. Stephen Liu, as well as Dr. Upal Basu Roy. Welcome, Dr. Liu and Dr. Roy. Can you begin with introductions?
Sure, thanks, Dr. Agarwal. So my name is Stephen Liu. I'm a medical oncologist from Georgetown University in Washington, D.C., where I'm director of the Thoracic Lung Cancer Program and Developmental Therapeutics. Happy to be here. Great to see both of you again.
And Dr. Roy.
Thanks, Dr. Agarwal. My name is Upal Basu Roy, and I'm the Vice President of Research at Longevity Foundation, and I'm thrilled to be here to be able to present the patient perspective. So thank you for inviting me, and I'm looking forward to a great discussion.
Fantastic. I'm so happy to be here with both of you. A lot has changed in the last 3 months. So I thought, Stephen, I would ask you how your practices have changed during the COVID-19 pandemic, and how did you manage your patients through the peak, and how are you managing now when most cities are starting to open back up again?
Yeah, my practice today has such little semblance to my practice 6 months ago. It is completely different. From the moment you walk into the hospital, the hospitals are much less crowded. We are still instituting a no visitor policy to decrease the number of people within the hospital. And so there are fewer people around. Our waiting rooms are spaced out. Our infusion center chairs are spaced out. And much of my practice now is telemedicine. And so the personal interactions that we would have in the clinic are replaced by interactions like this, really in an effort to try to minimize exposures. And what we learned early on in addressing the COVID pandemic is the exposure risk really seemed to correlate with risk of contracting the virus. This is a highly contagious virus. And by keeping our distance, by using telemedicine, preventing patients from coming into the clinics and the hospital as much as we can, we feel we're minimizing that risk. Now, not all of our patients can avoid trips to the hospital, but the main way in which my practice has changed has been a wide-scale implementation of telemedicine and really different strategies to try to keep patients at home and minimize the number of trips to the hospital and minimize the time in the hospital. Have you done sort of similar strategies, Charu?
Yeah, very similar. I think we were early adopters of telemedicine. So as we, sort of went into quote unquote lockdown in, the second, third week of March, we started doing more telemedicine visits. And I think now we are phasing out, where we're seeing, some patients in clinic and some patients still via telemedicine. But I think one of the points that you made is very important, that we have been able to do this safely or provide care safely by really limiting exposure. So we have now, as we are re-entering, we have physically distanced waiting rooms. We have a no visitor policy. We have thermal screening at all entry points. We have, even the infusion room appointments are staggered so that there is minimal overlap between the chairs. And, the radiology appointments have been also extended to be able to fit in, cleaning time, as well as making sure that there is no overlap between patients. all the patients that I've actually spoken to over the last couple of months who've come in to get their scans have just been pleased with the way, their care has been handled, because actually there has been less waiting all around. What do you think, Upal, is going on from your standpoint in terms of what patients are saying?
It's actually very interesting, Dr. Agarwal, that you bring up telemedicine. In fact, both of you brought up telemedicine. And initially, when the COVID-19 pandemic hit, we sort of looked at telemedicine as sort of the panacea of distant care, that, we felt that telemedicine is going to solve a lot of problems. But one of the things that we've been hearing from the patient side of things is, patients sort of fall into two groups. There's this group of patients who are fine with telemedicine and getting that remote second opinion. But there's also a group of patients who love seeing their doctors. They love going into the clinic. They love meeting their nurses. And I think they're really missing that. And, they're really concerned about when that sort of is going to be opening up, which actually then sort of brings me to a very, very important question. I think, let's sort of face it that, COVID-19 is not going anywhere. Initially in March, we thought that this is going to be a short-lived pandemic and we would have figured it out by summer. And here we are in June. And we're still talking about COVID-19. And, as you mentioned, Dr. Agarwal, that different states are sort of opening up, shelter in place is being lifted, and phase 1, phase 2, phase 3 reopening is happening. So I think one of the big questions which, the lung cancer patient community is grappling with in this new normal or now normal, whether it's new or now, we don't really know. But one of the big questions that the patient community is grappling with is, how do we sort of resume normal life and learn to live with COVID-19? How do I keep myself safe in this time? How do I go back to work? How can I go back to the clinic? How can I make sure that my doctors are taking precautions to keep me safe? And very simple questions from the patient community, such as, I'm going in for a CT scan and I'm supposed to drink the contrast. Is it okay if I take off the mask for a few seconds and drink the contrast? So this tangible, palpable fear in the patient community is real. And as one of our patients very eloquently put it, is it worth dying from lung cancer or is it worth dying from COVID-19? So I think the big question right now that remains to be answered is, how do we resume normalcy and lung cancer care with living with COVID-19? And I'd love to actually hear both your perspectives and how both your institutions are sort of addressing this moving ahead, because both of you are in very, very urban areas. And a lot of patients we've surveyed recently, they're in COVID hot zones and they're also in urban areas. So I think your experiences and your individual practices would be incredibly helpful for our patient community.
Yeah, so Stephen, would love to hear from you about how do we best transition back out into the world without being fearful of COVID? And, as Paul said, what are our best practices and what should we be doing, or what are we doing?
So how do we do it? In a word, carefully, right? We know that this is a risk that's going to be there for the long term, and we don't have all the answers yet. I think that some concern about COVID is wise and is healthy. And we don't want to go back to the way things are while the risk is still very present. So the distancing within our waiting room and our infusion center, that is really in for the long haul. And telemedicine is now a part of our practice. Whereas I had clinic 2 days a week, now some of those will be devoted towards telemedicine. And, there are some advantages to telemedicine. Access is an important one. Patients don't have to drive quite as far. There's less waiting for some patients, although I tend to run my telemedicine clinic pretty similar to my regular clinic. So I'm always a little behind, just for nostalgia, I guess. But, telemedicine is not going to replace the in-person visits. There is still a role for examination, for seeing patients in person. One thing COVID has done is really brought to light a lot of disparities in care, and just realizing how many of my patients don't have access to webcams, smartphones, internet, really can put that a sort of make telemedicine somewhat difficult. And personally, while I appreciate the safety and I'm a strong advocate for the use of telemedicine, it is not nearly as satisfying for me as sort of sitting next to a patient and really walking them through this journey and really making that connection. It's difficult to do over the computer, and in person now it's difficult to do with a mask. So I long for the days when we had in-person clinic. I just think right now the risk is a little too great for us to abandon these policies, and we really need to find ways to integrate them. So I think that use of telemedicine will go forward and will not completely replace our clinics, but it will remain an important part of one of our many mitigation strategies to reduce the risk and exposures to COVID. And I think that one of the other things we're doing is really looking at the treatments that we're choosing. Whereas we have several different options, maybe we're choosing different regimens based on risk, and we have to factor in frequency and dosing intervals. Have you seen that change in your practice, Charu? Are you maybe choosing slightly different treatments or regimens based on the risk of exposure?
Yes, so I would say that we're doing pretty much similar approaches as you outlined in terms of making sure that we are using telemedicine and minimizing exposure. As we are going back into our clinics, again, we are staggering visits. One of the things that I think has really worked out well is making sure that a few providers are in the clinic spaces and not everybody is in clinic all at the same time. In terms of choosing regimens, I think it's all about risk benefit and really taking each individual patient's disease into perspective in terms of offering them treatment approaches. So I certainly would like to discuss the use of, Q6 weekly dosing regimen, for example, for immunotherapy that is now FDA approved, or perhaps using a Q4 week interval for patients with small cell lung cancer when it comes to dosing immunotherapy, be it with atezolizumab or durvalumab, which has been recently approved. But I, at this point, haven't really quite erred on the side of just giving immunotherapy if I thought that somebody should benefit from chemoimmunotherapy, except in my patients, that have had known, positivity for SARS-CoV-2 or have had COVID-19 disease. I think that's a completely different equation. But if we are talking about, physical distancing and social and isolation and wearing masks and hand washing, and, if people are, taking precautions to make sure that they're minimizing their exposure, I've been able to offer them, the regimens that I would offer otherwise. We have another question here. How can lung cancer patients minimize their risk as states start to open up? And, one of the things that I talk to my patients about is making sure that they're masked, that they're washing hands frequently. And, if they are choosing to meet people, which, I don't really recommend that they go out and about and meet anyone and everyone. But let's say if they want to visit family members, again, do it in a physically distant way. And again, I don't think the point is to physically and socially isolate you all your life. And this is something that's not going away in the immediate future. So we have to, come up with strategies that work well for everyone. Upal, what would you say would be some other strategies that we can share with our patients here?
I think, as you pointed out, Dr. Agarwal, I think reminding our patients that this is something that we have to live with for the time being, and that this is not permanent, but also sort of making sure that they are secure and they are safe and they're supported by folks such as you guys is incredibly important. And I think reliable sources of information, because I think one of the things that we can all agree upon right now is the situation is evolving really, really rapidly. Just today, the WHO talked about how asymptomatic carriers are probably not the biggest spreaders of COVID-19, and this was not thought to be true a couple of weeks ago. So the information that our patient community is getting is changing rapidly. And so I think we've got to make sure that they have access to the most up-to-date, the most accurate information. And I think as patient advocates, I think that's something we've been doing regularly to make sure that patients get this up-to-date, curated scientific information, because I think having a lung cancer diagnosis is enough, but having to sort of curate and read about COVID-19 is absolutely crazy. So one of the things that we as advocacy groups that we've been doing, and this is in collaboration with my colleague, Dr. Amy Moore at GoTo Foundation, and Janet Freeman-Daly, who is one of the co-founders of Ross Wonders, one of the things that the three of us have been doing very regularly, weekly, in fact, since the pandemic was declared in early March, is to come up with weekly scientific updates for the lung cancer community, especially to give them some of these tips on how to live with the disease as the pandemic is evolving. And we have covered different aspects of the disease, such as social distancing. Should I travel? Should I go back to work? Some of those really practical tips, and getting that information from credible sources such as the CDC and WHO, and also curating some of the recent medical literature about the use of hydroxychloroquine. Again, lots of conflicting information out there. Some studies saying it's good, and then recently we know that some of those studies were disproven. So again, I think for our patients to keep themselves up to date with how to live with COVID-19 is incredibly complex, and I think that burden should fall on us as a community to make sure that we provide them with these tips to successfully navigate this situation. And Dr. Liu, you talked about the issues with telemedicine and the digital divide, and Dr. Agarwal, you talked a little bit about dose reduction and sort of the risk-benefit analysis. So one of the concerns that we've heard a lot from our patients is that when we are doing telemedicine, that aspect of shared decision-making, the fact that you sit in the office and you have the discussion about risk-benefits of a treatment, is that same element maintained during a telemedicine consult? And I would love to hear both your perspectives on that.
Stephen, you want to?
Sure, very much so. I think maybe even more than before. When we're discussing different options and going forward with a patient, I think that, Charu and I are very comfortable with our knowledge of how to treat advanced lung cancer, about applying best standard practice. But at the start of this pandemic, there were so many uncertainties on our end as well. And, we would stay up late at night wondering if we had made the right decision. If I feel someone needs to move forward with this treatment or a clinical trial, and if that person were to contract COVID, I would feel very much responsible for that. And so I think that the shared decision-making model probably applied more than ever, to be very upfront about the uncertainties. We have to balance the things we know about lung cancer treatment, about the very real risk of this highly lethal disease, with a lot of the uncertainties and the things we don't know about COVID.
Yeah, I think we spend a lot of time now, more so than ever, about, really evaluating the risk of each and everything that we do. Treatment obviously is the most obvious thing that we talk about, but we also weigh in things like, where are my patients going to get their blood work, right? I mean, which facility am I sending them to? Do I really need the scan right now, or can I wait for another 2 weeks, 4 weeks, 3 months? I mean, there are certainly patients of mine who are on oral drugs where we've had risk-benefit ratio discussions, and we've talked to them about, clinically they're doing really well. And I think it's in their best interest, especially if they're older, to maybe avoid a CAT scan right now and delay it for 4 months. So, I think not just actual therapy, but, each and every decision is being weighed very carefully. And, when I sit down at the end of the week to look at my next week's schedule, I'm sitting down with my clinical staff and making sure that, we triage patients accordingly. We are making sure that only those patients that absolutely need to come in are coming in. And patients who don't need to come in, we are coming up with a strategy every week. Are these patients telemedicine? Are these patients going to be moved to 2 weeks down the line where we'll have maybe even more resources at hand? So I think these discussions are happening on a very granular level, and I've not done this much planning in a very long time. So it's actually really beneficial to patients because everyone's thinking about this very carefully.
But I think that I think an important message that's important to get out there, in all of our cities, is that hospitals are safe to go to. When you need to come to the hospital, we are hyper vigilant about the risks. We're taking all of these precautions. For patients who need to be in the hospital is a safe place. And that message, I think, is being lost, because what we're seeing across the country, particularly with New York, Upal, is that a lot of the very common medical diagnoses are decreasing in incidence pretty precipitously. If you look at ST elevation, MI, certain types of heart attacks, asthma admission, those incidences are dropping by about 40% in a lot of places. New lung cancer diagnoses are going down. And there's no biologic basis for that. That's not really happening. It's just we're not picking those up because patients are not coming into the hospital in an effort to try to minimize their risk. And I think the real lesson is if you don't need to be in the hospital, if you don't need to be around the hospital, the clinics, then you shouldn't, for everyone's sake. But if something is wrong, you need to seek attention because lung cancer is a lethal disease. We need to pick this up early. And when it needs to be treated, it's not going to wait for the pandemic to calm down. We need to move forward with proper treatment.
Yeah, so one of the things that you mentioned, Upal, were these weekly updates. Is there a place that patients can go to access them since they're curated and sounds like would be a great resource?
Absolutely, Dr. Agarwal. So if you go to any of the patient advocacy group websites, our homepages, if you go to the Longevity webpage or to the GoTo Foundation webpage or the Lung Cancer Foundation America webpage, we all have a dedicated COVID-19 spot on the front page itself. And if you click on the COVID-19 webpage, you should be able to access all the weekly updates that we put out right since the beginning of the pandemic. And actually, I had a quick question for both of you, since I brought it up about the scans and, opening up, taking off the mask while, you're drinking your contrast. What is that safe for patients to do? And do you have any words of wisdom to share with our patient community when they're doing this? Because this is obviously something that our patients would have to go through when they're getting diagnosed and when they're getting monitored.
So I can give you my advice. And when the pandemic first started and when I had inpatient responsibilities, I was really concerned about exposing my family, my wife, my daughter, at the time I didn't know, maybe my dog, to COVID. And so I wouldn't wear my normal clothes I'd bring in the house. I would wear scrubs and I would change in the garage and then come home and then wash up. And, I haven't worn scrubs since training. It's been quite a long time. And I'm not used to doing procedures as a medical oncologist. My wife is a surgeon, and probably a few days into it, she watched me changing in the garage, and she was incredulous that I didn't know how to do anything. Apparently, I get undressed like a child, and I take my scrub top and I pull it over. And she says, "You need to think of every surface as covered in paint. And if you're pulling your shirt over your face, you're getting paint all over your face. So you pull it up. And when you take a mask, every surface has paint on it. So if you want to touch the rope that's around your ear and pull it out to the side and then drink this, consider every outside surface as covered in paint, and you don't want the paint to get into your mouth, into your eyes. Everything is contaminated." So I would take off the mask with one side. I wouldn't put it down on a table. I wouldn't touch the front of the mask. Then I would drink the contrast, preferably when no one is right next to me or around. Afterwards, carefully put it in there and just be very conscious, move slowly and deliberately. And it's really just an awareness. And after a while, you kind of get used to it. Charu, I'm not sure if you have any other tips you've picked up along the way.
I learned so much already about this mask technique. I think I can't top that. No, that was great. I would just say, as long as patients are, isolated and, you're in a space where, you don't have somebody, at a very close distance to you, I think it's reasonable to take the mask off momentarily and drink contrast. I really don't think it's, that problematic. But I really like the technique that you pointed out, Stephen. Another question that, some of my patients have asked me, and this is coming up again here as well, is it a good idea to wear a face shield, mask, and gloves on subways and buses now that more people will begin using them? I've certainly seen an uptick in people wearing face shields instead of masks. So what are both of your perspectives on this?
I can go first. I think gloves are a good idea, but again, it's really just a matter of awareness and being aware that you're wearing the gloves and that the surface of the gloves is something that's may have come into contact with COVID. And so if the gloves help you remember not to touch certain things, I think that's a good idea. It's sometimes difficult to constantly wash your hands. You may not always have access to it. So I think the gloves are important, but if you're wearing the gloves and touching your face and touching everything else, then they really serve no purpose. So wearing the gloves, I think, is a good idea, but just to call an awareness to not transmit things from one surface to yourself. face shields are things that I've not fully adopted. As you know, we wear them when we go into known exposure rooms. We wear them before procedures, primarily anything that's going to generate aerosol at a high risk of transmission to the eyes. But in day-to-day practice, it's not something that I've adopted. Upal, I'm not sure if you have a different opinion there.
I'm actually going to use your analogy, Dr. Liu, about, every surface covered with paint. And, even if you're wearing gloves, you have to assume that our gloves are covered with paint. And one of the things that we've been telling the patient community is just because you're wearing gloves, it's not a replacement for hand washing. So even after you take off your gloves, you need to wash your hands. And as you pointed out, Dr. Liu, just because you're wearing gloves, that, not touching your face and other parts of the body. So gloves are, sometimes it can be sort of, they're good, but at the same time, we can't take them as absolute security blankets, for lack of better words, and we can't replace the usual tactics of washing our hands as much as possible and not touching any part of our body as possible when we're wearing gloves. And to your point about face shields, Dr. Liu, I think I've started seeing that more and more in New York City as well, as people are going back to work and as places are opening up. I've seen that a little bit more, but again, I find it very interesting because the three of us, we live in cities and where lots of people use public transport and there are buses, and I think this is something maybe we'll be seeing a little bit more often, people wearing shields a little bit more, but again, it's not as common right now, at least in New York City.
Yeah, and I would just say that gloves don't take the place of hand washing. So sometimes, with the whole paint analogy again, I think can increase your risk of touching different surfaces and not even realizing. So I think I usually advocate my patients to, carry a hand sanitizer with them if water and soap is not available, and to effectively and efficiently wash hands as much as possible throughout the day. I mean, there are times during the day when I'm washing my hands like literally every 5 minutes, or at least using an alcohol sanitizer. So I think we have to just be mindful of effective and efficient hand washing. Should we be taking any special precautions when our patients' spouses go out into the world, like if they are shopping, seeing people? I had a question from one of my patients where, her children would be going back to camp. She can't really obviously prevent her kids from mingling with other kids. So what should our patients be doing? Upal, I'll start with you. What are you recommending on these resource websites?
This is, again, something we hear a lot because our patients, they have caregivers, and a lot of their caregivers are going back to work right now with patients at home. And again, this question comes up repeatedly: how do I keep my patient safe? The patient asks us, how do I keep myself safe from our caregivers? And we actually tell them, as much as possible, still maintain social distancing if that's an option. And, when your caregiver comes back home, make sure that you take all precautions, washing hands and, getting rid of the clothes that you've been wearing outside and, trying to be as clean as possible. And this is sort of the advice we give, that, assume that everyone around you is maybe infected and, behave as safely as possible. So when you come back home, take all the precautions that you would do as if you had been exposed, essentially cleaning yourself, social distancing, using hand sanitizer, washing your hands as much as possible before you talk to the patient or before you talk to the caregiver. You make sure that your caregiver has taken all of those precautions. I think let's just, and this is something we are learning, that, it's impossible now to just stay at home with shelter in place being eased, and people going back to work. So this is something we'll have to deal with more and more, people within a family or within a household exiting either to go to work or to do groceries or to run errands. And I think this is something we'll have to, come up, talk more and more about, how to keep our patients safe within each household. And I would love to actually hear, Dr. Liu, what advice you have for your patients and their caregivers during these types of discussions.
Yeah, it's evolved a little. Right? When the pandemic was first starting and we thought this was going to be very temporary, very transient, as you said, we thought the summer we would be through it. We're really encouraging people to stay at home at sort of all costs. Now, as we look forward, without a clear end in sight, I think it's maybe a little unreasonable to ask patients to be so isolated. And I think that one of our colleagues, Dr. Farrago, described COVID as a very lonely disease because to keep the absolute minimal risk, yes, if you're in a room with no interaction with no people for the next 3 months, your risk will be very, very low. But it's a very difficult way to live your life. And, family is a very important part of our life. These social interactions, we're social creatures. And so while I wouldn't say I've relaxed all risk warnings and precautions, I think expanding those circles and reintroducing some aspect of normal life is healthy. And you want to do it in a safe way. An important message, as you mentioned, a lot of hand washing, distance, masks, all of that. But also early recognition of any concerning symptoms. If this were 6 months ago and you developed a low-grade fever, you developed a new cough, you might just have a cold and might not even bother telling anyone. I think now we view those symptoms a little differently, and early testing, early recognition is only going to help in terms of management, mitigation, isolation, quarantine. So early recognition of symptoms, open communication with your healthcare team, I think are really important to start to reintroduce some aspect of normal life. Yeah. Charu, I don't know if you have any other tips.
No, and I think I've been encouraging my patients to return to some kind of normalcy because, as you said, I think it's important, especially as these shelter-in-place requirements start to ease off. I think it's going to become our new normal to live with this heightened sense of not just recognizing symptoms, but also just being careful around each other and having some form of responsibility, not just to ourselves but also to the society. So I agree with what's been said. One other question that has come through is, do patients with COVID-19 and those needing treatment for lung cancer have separate locations or rooms in the hospital? And how can we be sure that the CAT scan machine in a hospital setting is safe for lung cancer patient, and are the machines shared with COVID patients? So I can start off by, sort of giving an idea of what we're doing. So when patients in our hospital are admitted for a diagnosis of COVID-19 or a SARS-CoV-2 infection with an associated, either a pneumonia or spectrum of COVID-19 disease, we have isolated those patients on our COVID-19 units, be it the ICUs or step-down units that are dedicated for COVID-19, as well as for a term that we call persons under investigation, or PUI, those people where we may not have the test back, but we have high suspicion of COVID-19. All other patients who are admitted and have tested negative for the SARS-CoV-2 infection are isolated away from the COVID-19 units and are really in a place in the hospital where they have absolutely no interaction with either staff taking care of COVID-19 patients or any patients who may have the COVID-19 disease. So that's on the inpatient side. And on the outpatient side, recently we have instituted a new policy that anyone getting any kind of interventional biopsy, be it bronchoscopy, colonoscopies, endoscopies, procedures and or biopsies, let's say it's a CAT scan guided biopsy, everyone's getting a test before they come into the interventional suite, so as to, again, minimize exposure to both the intervening staff as well as, the ancillary staff, as well as other patients. So I think, that's an important step to prevent, spread of the disease. And even though the CAT scanners are not dedicated as COVID-19 scanners or non-COVID-19 scanners, there's a thorough deep cleaning and, washing and sanitizing that goes on in between patients. And that's the reason why patient appointments are now staggered. Earlier, if a patient appointments used to be 20 minutes long, and I'm just making it up. Now they are 40 minutes long or twice as long sometimes, just to allow for that deep cleaning time in between patients. And that's been our strategy to reduce exposure. And, as Stephen said earlier, I think hospitals are actually one of the safer places to come during COVID-19 because they actually have it figured out, how to separate patients that are infected from non-infected and making sure that all sanitary requirements are in place. What do you think, Stephen and Upal? Stephen, I'll start with you.
Yeah, I agree. One thing I would say is if you're curious, call and ask. And I think that the department should be able to tell you what their cleaning process and procedures are. And if they don't tell you anything, they may not really have one. But I was very impressed at every radiology group I've talked to. It's something that they're very aware of, and they're taking those steps to decontaminate and do really deep cleaning between patients. And as a result, we have a little bit less capacity for scans on a day-to-day basis. Our machine used to turn around very quickly. Now there's a lot more time in between. And in response to that, we're doing more scans in the evenings, scans on the weekends, to try to accommodate the time it takes to properly clean in between. And so hospitals have those procedures in place. And if you're not sure, I would encourage people to ask, depending on where you are.
That's actually very helpful to know, Dr. Agarwal and Dr. Liu. And those are the types of questions we've been getting a lot from our patients as well. Is there a dedicated COVID-free zone in every hospital? And another question that we get a lot from is also infusion rooms. Essentially, we know that there are cancer patients who have COVID-19. Let's face it, that that's sort of the reality of the oncology world. And some of them will probably be getting infusion, be in active treatment. And we've heard this question that are infusion rooms safe from COVID-19 infections? And then another question we get a lot from our lung cancer community is, especially where infusions and doctor appointments are concerned, and now that people are going into hospitals, is it safe for me to go with a caregiver, or do I have to go by myself? So I'd love to actually hear how both of you are sort of handling that, the infusion side of things, and also what are your recommendations about having a caregiver, especially if a patient is having an infusion and need someone to drive them back, or a procedure under anesthesia and then they need someone to drive them back.
Yeah, so I can take that first part first. So in terms of infusion areas, at our institution, we actually have a dedicated COVID-19 infusion area as well. That's actually separate and removed by floors from the other treatment areas. So anyone who presents to clinic with, either with a temperature or with symptoms, and we want to get rapid testing, is actually then triaged to that floor. And as you know, there have been patients who've had the infection, had the disease, and are now recovered and need treatment, are actually being treated in those infusion rooms rather than the infusion rooms that we have for all of our patients. So there is this physical separation that we have created, not just on the inpatient side, but also now on the outpatient side, which has been quite helpful.
Yeah, we don't have a separate location. Again, I think that a lot of facilities will be limited by their own space and sort of what they can use. We had some extra space, but it was used for the reason. So we don't have a separate place for COVID positive patients, but generally when our patients are COVID positive, we are not treating them in the infusion center, even if they are suspicious. Cancer treatment is not an elective procedure, it needs to move forward, but there are very few treatments that couldn't wait a few days or a week to really know if people aren't COVID positive. So if we had someone to come in with any symptoms, with a fever, they frankly would not be allowed into the infusion area. We would need to test those patients first and be sure that they were not positive. And if one of my patients who required intravenous infusions for the proper treatment of their lung cancer, if one of my patients had developed a COVID-19 infection, I would hold treatment, really delay treatment until they got through that acute infection. And I think those delays can be accommodated with most of the treatments we're using. I think we become comfortable with that. Char, do you agree with how would you handle someone who was receiving chemotherapy a few cycles in and did contract COVID-19?
Yeah, so I would say that at this point in time, I'm just not confident that proceeding with treatment while they're, obviously while they're infected and being treated for the disease, chemotherapy is probably out of the question. But I think, we would probably use a lot of caution and, use disease assessments and really have conversations with the patient about the risks and benefits of starting chemotherapy versus waiting perhaps, 2 weeks, 4 weeks, and assess what their disease is doing before we go in, restart chemotherapy. I think, there have been reports that have come out both at the AACR and the ASCO meetings that, there are certain risk factors that can predispose to higher mortality, especially in patients with lung cancer, and those seem to be universally related to the receipt of chemotherapy. It sounds like, immunotherapy and the use of TKI may not really have that implication. But I think when you're using myelosuppressive chemotherapy, there's definitely a risk. And I think at this point in time, if my patient is maybe 6 weeks, 8 weeks, 10 weeks out of their COVID-19 disease and really doing fine, not on oxygen, back to normal, I mean, that's a different situation than somebody who's just been discharged from the hospital 2 weeks ago.
And so Dr. Agarwal, sorry, go ahead. Now, I was going to actually, Dr. Agarwal, you talked about, patients receiving chemo having worse outcomes, and the recent studies that were shown at AACR and ASCO, the Teravold registry, for example, which talks about following lung cancer patients with COVID and having worse outcomes with chemotherapy. Is that something specific to lung cancer, or is that sort of, do you think that any cancer patient who's receiving chemotherapy would be sort of having that same sort of risk? Because our community is incredibly worried when they read these types of studies that, getting chemotherapy sort of predisposes them to having a worse or a more severe form of COVID. So what are both your thoughts on that, about these types of studies and how our community should be taking them into consideration when they decide their treatment?
So I can go first. Yeah, the early studies that came out from COVID, especially with regard to the risk of our patients with lung cancer, came out of Wuhan, China, and Italy. And I think what we're learning as we move forward and gather more information through Teravold, through the CCC19 registries, is that those populations weren't necessarily representative of the U.S. population. Treatment for lung cancer, care for lung cancer, is very different depending on your geographic region. For example, in China, almost all treatment is done in the hospital, often overnight, whereas in America, that's very unusual for us to do that in the U.S. But we see those numbers and some of the outcomes, which were frankly quite poor, especially with regard to the severity of disease, with mortality, patients who had lung cancer. It's not meant to be a scare tactic or to remove hope or to scare people away from chemotherapy. I would view those as understanding there is some risk involved, and so we need to weigh our decisions very carefully. But an untreated lung cancer or an undertreated lung cancer, I would argue, is a greater risk. And so if our patients really need that treatment, we do need to move forward in a safe way. We don't want to undertreat this disease. We want to minimize risk without compromising outcomes in any way.
And I would just add, I don't think that the relationship of receipt of chemotherapy and mortality is only true for lung cancer. I think we've seen it for other cancers. We've seen it from the French data. We've seen it, from the Spanish data that were presented at AACR. And frankly, we saw it in the CCC19 data that were presented at ASCO, that no matter which malignancy there is, chemotherapy use is associated with slightly worse outcomes. But then again, I think it's not a matter of lung cancer versus breast cancer. It's a matter of myelosuppressive chemotherapy. Now, having said that, I will also add that early on, we recognized that this may be a risk. So we acted upon that, and there were sort of these less or moderately suppressive myelosuppressive chemotherapy regimens, which don't cause a lot of decrease in white blood count as well as hemoglobin. But, recognizing that there may be a higher risk, we as oncologists started to administer growth factor support to be able to support patients through their reduced white blood cell count phase to be able to avoid this higher risk for infection. So I do think that, there are strategies that can be put into place to mitigate this risk. And as Stephen said, I think this is something that we can't take lightly. If somebody requires treatment, it's a matter of making sure that we provide all of the support that we can to administer treatment safely.
Yeah, I think that if I have someone who's requiring intravenous chemotherapy and we need that treatment to get the best outcome, we'll move forward with that, but I'll still try to minimize exposure every step of the way. So even if they live across the street from the hospital, our visit before chemotherapy can still be virtual, can still be through telemedicine, just to minimize the interaction with me and with my nurses and my team and the waiting room, try to minimize those. When we're reviewing scans, for example, we can review scans through telemedicine by sharing the screen, throwing the images up there, walking them through it. That technology was forced to be in there very quickly. And as I'm sure you both are very strong proponents of biomarker testing and molecular testing, how do we try to minimize risk while still getting the information we need to treat lung cancer properly? And this is where I think we've seen a lot more use of liquid biopsy, at least at our institution. Char, have you found that, I mean, you've always been using a lot of liquid biopsy, but do you feel it's even more so now?
So I wouldn't say our use of liquid biopsy has increased. I think it's about stayed the same. It hasn't decreased because I've been able to use supportive services like, phlebotomy services that some of these diagnostic companies provide, which has been a great help. I just had somebody who had inadequate tissue on their biopsy, which doesn't happen uncommonly. I mean, it happens about 30 to 40% of the time where we don't have enough tissue to do all of the testing. And I was able to get, an actionable result on a liquid biopsy. So I think it's a great advancement that we should continue to use, and which has actually been a very helpful tool during COVID-19 pandemic. Earlier, 6 months ago, I may have said, let's just bring them in for another bronchoscopy, get more tissue, plasma. But I think I'm maybe relying a little bit more on plasma this time around during the pandemic than going in for another repeat biopsy. So I think it's been very helpful. So, Stephen, you talked about sharing results and scans with patients over telemedicine. Are you able to use software where you're able to screen share? How are you handling scan reviews?
Yeah, so the software we use is HIPAA-protected software through the hospital, and we can share the screen. And so we'll talk by camera, much as we're doing now. I'll pull up their scans and their labs, and we can share the screen, and I can walk them through it. We also have the ability to call in a third person, very much like a meeting like this, where that third person may be another family member who's far away. And in that way, that's something that I really wasn't able to do in the clinic. Now I can have family members from other parts along the way. For our patients who need a translator, this has actually been very convenient to have a translator available on this call because we can conference in multiple people. And it's also a way that we can do our multidisciplinary care. For locally advanced lung cancer, it's very important, as you know, to have input from surgeons, pulmonologists, radiation doctors. We would have multidisciplinary clinics where we would all be in the room with the patient. Now, obviously, that puts everyone at too great a risk, but it's actually quite a bit easier to do that through telemedicine. I'm not sure if either of you had similar experiences.
Yeah, I would say that in addition to what you've said, we've actually done some multidisciplinary visits with our patients, which have actually been very well received, where, we have myself and, family member, as well as a patient, as well as a radiation oncologist who's, all in this video sort of conference room together. And we talk about, pros and cons of doing let's say chemotherapy and radiation together, or radiation first and then chemotherapy later. So I think those kinds of sessions would not have been possible, if it wasn't for telemedicine. And we do have the screen share ability, which has been fantastic. Sometimes the screen gets really, really small and the patients are unable to see it, especially if they're on their phone, but they appreciate the effort. And we've been able to use, our EMR's messaging function to go back and forth a lot more efficiently now that, a lot of us are using telemedicine. We're using the messaging system to share information on new drugs. We're doing a lot of our consenting, verbally. So to be able to share all of this information instead of handing out printouts, I'm sharing a lot of things electronically. I'm also sharing images and screenshots sometimes, which has been extremely helpful and well received. Upal, this has been a very challenging time for patients. Can you talk about the psychosocial impact of COVID-19 and what resources might people have to turn to?
Absolutely. And I think that's, when COVID-19 first sort of became a part of our vocabulary, Dr. Agarwal, we heard this from our lung cancer patients that we are very resilient. We already have a terminal diagnosis, and nothing can phase us. But the reality is, I think the pandemic evolved so rapidly, and knowing what we now do, I think wellness and psychosocial well-being is, I think, incredibly important for patients as well as their caregivers. I think we need to be cognizant of that as well. And I think a couple of resources, and I think all of us patient advocacy groups, we've sort of taken that to heart. And if you check out any of our websites, as I said, we have a dedicated COVID-19 page, all patient advocacy groups, and we have a section specifically dedicated to mental health. Essentially, we have videos with psychologists, with psychotherapists. We have videos in mindfulness and meditation, and essentially sort of how to adjust to the new norm. So I would highly recommend that you check these types of resources out. And some of the other tangible resources, and when we talk about psychosocial well-being, I think we also need to realize that the psychosocial aspects of living with COVID-19 come from some really, really tangible fears. And those tangible fears are, we talked a lot about those tangible fears. Essentially, how do I, sort of adjust to the new norm? How do I adjust financially? And I think, I would also recommend that check out a couple of other websites for financial resources. Cancer Care is one of them. And we at Longevity, we have a dedicated financial resource services only for COVID-19, for the lung cancer community and those who are impacted by COVID-19. And I would also recommend that check out Patient Advocate Foundation. So this is, again, sort of, really realizing that the psychosocial well-being of our community is dependent on all these different factors, how to keep patients safe, how to make sure that patients can go back to work safely, how their loved ones can go back to work safely, and then finally, the real psychosocial aspects, which is mindfulness and meditation. So again, as I said, we all have resources on our website, and I encourage you to check them out.
That's great. We certainly had used our counselors a whole lot more, especially in our patients who had new diagnoses during the COVID-19 pandemic. These are unusual times, and they're often having to break these news over phone calls or video calls to their family members. And, it's really trying times because family members are unable to come by and offer support. Mm-hmm. So we have used our local counselors actually much, much, much more during the pandemic. It's been extremely tough for people. Stephen, have you faced any challenges in terms of patients feeling a lot of stress, and have they shared with you what their coping mechanisms would be?
Yeah, I think it comes up a lot during our telemedicine visits, and sometimes these visits end up going a lot longer than we had planned, because for a lot of patients, it's maybe the only interaction they have for weeks at a time. While it is very difficult to be away from family and from loved ones, we also appreciate that some of our patients, maybe don't have a lot of family or a lot of interactions, and their interactions were more social with friends, and those really have even more so gone to the wayside. And so the interactions we have with telemedicine end up being in some parts social as well. And I think that's really important, just to know how isolating this whole process is.
And one of the things which I feel is highly underutilized in cancer care in general, which is palliative care, which has a huge mental health component to it. That's one of the things that we've been also telling our patient community, that if your hospital or your clinic has palliative care services, which has a mental health component, then you should be tapping into it, because they're really there to help you navigate these incredibly stressful times. I think having a lung cancer diagnosis is stressful enough, but coupled with the pandemic and the isolation that comes with the pandemic. So that's another thing that we've been telling our patient community to be really sort of accessing the counselors, as you talked about, Dr. Agarwal, essentially the palliative care services that clinics and hospitals also have.
Absolutely. Another question that has come through to us is about staging of lung cancer. And, we, of course, are seeing new patients diagnosed with lung cancer during the pandemic. Stephen, how are you handling staging under these circumstances and during the pandemic?
The process we use to correctly stage lung cancer, the tools we use hasn't really changed much. In order to fully stage a cancer, we will biopsy that cancer. Biopsy is still being done. Mediastinal staging, when relevant, is done typically by bronchoscopy or endobronchial ultrasound. That's through a pulmonary medicine specialist. And that is an aerosol generating procedure. So it is important patients are not COVID positive when they have that procedure. So before bronchoscopy, I think as you'd mentioned, Charu, at your hospital, ours as well, before any scheduled bronchoscopy, patients will actually have a COVID test 2 days before the procedure, make sure the test is negative before going forward. But apart from those testing precautions before procedures, the radiographic staging, the biopsy staging is still happening in the same way. We review all of our new diagnoses at our multidisciplinary tumor board. That tumor board is now virtual. And so we're reviewing scans, reviewing biopsies with our pathologists, all virtually through shared screens. And, I think for tumor boards, that actually works quite a bit better. And attendance has really gone up for those because they tend to be very early in the morning.
Upal, any comments about, staging or some things that patients should remember?
I think Dr. Liu's comments about how hospitals are sort of taking precautions, I think is incredibly helpful, because we've heard stories from a lot of patients who've been symptomatic and they've sort of deferred going to get staged, going for their diagnostic workup because of fear of contracting COVID. So it's very heartening to know that hospitals are now equipped to be actually able to deal with all of these staging procedures and making sure that our patients are safe and they can get staged without the risk of exposure to COVID-19. So that's incredibly helpful for our community. Thank you.
That's great. Any final thoughts before we ask for the final round of questions? Stephen?
Yeah, I think that sort of building on what you'd said, Opal, the hospitals are safe places to go when we need it. What we're worried about, the impact of COVID, is a stage migration. We know that outcomes are related to stage. And when we have an earlier stage lung cancer, we have more treatment options. If we wait longer, if we delay things weeks to months, then someone we may have detected at a stage 1 may be a stage 2 or 3, where treatment options might be a little bit more limited, or someone who might have been a stage 2 or 3 might unfortunately progress to a stage 4 if we wait too long. We know these delays can compromise some of our outcomes. And so if there is concern, people should know that there are ways to get care safely. Have symptoms and you're not sure what they are, telemedicine, just to provide some reassurance or to help direct what we should do with those symptoms, can be a way at very low risk, at no risk of exposure, to really get some of those questions answered. So if you need medical care, if you think you might need care, you really do need to seek that care for the best possible outcomes.
And Upal, what can you tell us? What do lung cancer patients have to look forward to? I know there's a lot of research going on with the Longevity Foundation. Could you talk us through it?
Absolutely. And I'm Dr. Agarwal, I'm an eternal optimist, and I look at the COVID pandemic and I see what lessons have we learned from it. And, when you're talking about the fact that now, because of the pandemic, you're able to do remote consenting, which was something that we never thought about for clinical trials. Patients were asked to come in and sign in-person consent forms. And now, because of the pandemic, we've sort of evolved to conduct clinical trials differently, which I think is absolutely phenomenal, which will make clinical trials much more accessible to patients. Then the second thing you talked about is telemedicine. A couple of months ago, we used to hear that patients in one particular state, they could not get a remote second opinion in another state because of reimbursement issues and because their doctor was not licensed in another state. And now, because of the COVID-19 pandemic, doctors are getting licensed around, and we've heard of these wonderful stories. Patients living in New Jersey, they're actually going to your institution because now folks at UPenn are licensed to actually see patients from New Jersey. So I think the pandemic has sort of really made us reimagine care in ways that we never thought of. And that's the silver lining I see in COVID-19, that we are able to deliver care in different novel fashions. We are able to reach patients that we were unable to reach before. And Dr. Liu, when you were talking about doing a multidisciplinary tumor board over telemedicine and having the patients involved in that discussion, these were unimaginable before the COVID-19 pandemic. So for me, those are the silver linings.
A lot of good things are coming out of it. And, as oncologists, we share your passion about being eternally optimistic. So I think this is teaching us new lessons. And we'll spin them into as many positives as we can. Unfortunately, we are all out of time. If you'd like to watch this webinar on demand, it will be available on curetoday.com #webinars within the coming few days. And I want to thank our amazing panel, Dr. Lou, Dr. Roy, and the audience for attending and participating in today's event. I would also like to thank Cure and our sponsors, AstraZeneca and the Longevity Foundation, for making today's educational webcast possible. Don't forget to check your email tomorrow for the survey to be entered to win a gift card. And thank you all for joining. We'll see you next time. Bye-bye.
Thank you.
Thank you.
Thank you.